Dr. Edward H. Dennen will discuss the construction of the classical instrument and the technique of application. Dr. Dennen.
Thank you, Colonel Reaver. Obstetrical forceps, in a general way, may be divided into two types, the classical and the special. The classical forceps, for years, because of their type of construction and manner of use, have been considered as standard. The special forceps, those of more recent development, vary markedly in type of construction and technique of use from the standard. Certain forceps have distinct advantages under certain conditions. Others are definitely contraindicated. Some forceps fit molded heads, others round heads. Some instruments give a better application, accomplish rotation and deflection with less manipulation. Some instruments give a better line of traction. There is a choice of forceps which is desirable if one has a knowledge of the special type and can apply it under the desired conditions. Let us consider the classical instrument and its construction. The classical forceps is composed of two parts, each of which consists of a shank connecting a handle with the blade. The blade may be fenestrated or it may be solid. The blade is attached to the shank at a forward angle. This angle tends to correspond to the angle of the pelvis and is known as the pelvic curve. In addition, the blade has a lateral curve, which corresponds to the curve of the fetal head and is known as the cephalic curve. The outer surface of most classical instruments, the outer surface of the blade is beveled. The inner surface is flat. The shanks are either overlapping or they are separated. At the junction of the shanks with the handle is the lock. Originally, there was no lock to the instrument. Then it went through various stages of development to a fixed lock, semi-fixed lock, set screw lock, swivel bar lock, and then the pendulum swung to a sliding lock. The object of the fixed lock was thought to be to prevent slipping of the forceps from the fetal head. However, nowadays it's felt if one has chosen the proper instrument and applied it properly, there would be no necessity for a fixed lock. At the junction of the handles with the shanks are projections known as the finger guards. The handles of the classical instrument vary according to the ideas of the originator. Here you see we have the corrugations and a projection at the lower end of the handle, the intention being to prevent slipping. Again, with the modern concept of traction, there's less necessity for prevention of slipping. And if one follows the principle of the third-degree lever, applies traction from the finger guards, there'd be avoidance of compression of the handles, which might give force transmitted to the fetal head and causing injury. Here we have a first-degree lever, the hand exerting the force on the handles, compressing the handles, and it's transmitted to the resistance, fetal head, with the lock as the fulcrum. However, if we apply traction to the finger guards, we utilize the principle of a third-degree lever and apply our force at the fulcrum, thereby avoiding compression of the handles, which may give transmitted compression to the fetal head. Next, we go on to application. Now, the application should be cephalic. A biparietal, bimalar application is essential in order to protect both the mother and the child. And a true cephalic application is one in which the blades, in addition to fitting the shape of the head, tend to lie evenly along the sides of the head, filling the space symmetrically between the orbit and the ear and extending from the parietal boss to and well beyond the malar eminences. This can be demonstrated on the fetus. Here we have the blade lying along the side of the head, extending from the parietal boss to and beyond the malar eminence, filling the space between the orbit and the ear symmetrically without pressure points. It's not easy to determine an accurate application. However, one can be guided by three landmarks on the fetal head, and two on the fetal head and one in the forceps. These are the posterior fontanelle, the sagittal suture, and the lower angle of the fenestration. In carrying out these checks, one should have, with the forceps applied, the posterior fontanelle a finger's breadth anterior to the plane of the shanks and equidistant from the sides of the blades. The posterior fontanelle is more than a finger's breadth anterior to the plane of the shanks. We have the extended attitude of the forceps on the head. The blades move forward on the face and the toes dip backward beyond the angle of the jaw. The posterior fontanelle is a finger's breadth anterior to the plane of the shanks, and the posterior fontanelle is equidistant from the sides of the blades. The sagittal suture, throughout its length, is perpendicular to the plane of the shanks. If the sagittal suture curves off after it passes below the plane of the shanks, curves to one side or the other, that signifies the undesirable brow mastoid application, which gives unequal pressure on the tentorium. And finally, the fenestration, the lower angle of the fenestration, can barely be felt, if at all, in advance of the head. Now we'll continue with the technique of the application of forceps. Of course, it's essential that we keep in mind all the prerequisites to a forceps delivery, and having satisfied them, we proceed with the application. And An important point is the station of the head. The four major planes of the pelvis are as follows. First, the plane of the inlet, or the high plane, is represented by the red line, which extends from the upper inner margin of the symphysis to the promontory of the sacrum. 2, the plane of greatest pelvic dimensions, represented by the blue line, which extends from the middle of the posterior margin of the symphysis to the junction of the second and third sacral vertebrae. Number 3, the plane of least pelvic dimensions, or the plane of the ischial spines, is represented by the green line and extends from the inner lower margin of the symphysis anteriorly to the sacrococcygeal junction posteriorly and laterally to the ischial spines. And 4, the plane of the outlet of the low plane is represented by the black line, which extends from the lower inner margin of the symphysis anteriorly to the junction of the sacrococcygeal joint posteriorly and laterally is bounded by the tuberosities of the ischium. The 4 stations of the head: high station, the biparietal diameter of the head and the plane of the inlet are represented by the red line. Such a station would correspond to a high forceps. To the mid station, the blue line represents the plane of greatest pelvic dimension, or the mid-plane. And this would be a mid-forceps. The low mid-station is represented by the green line. And this would be a low mid-forceps. The plane of the outlet, the black line, coincides with the biparietal diameter and represents what would be a low forceps. The first exception to the aforementioned rules for station of the head: extreme molding. It will be noted that the leading bony point is near the outlet, but the biparietal diameter, represented by the blue line, corresponds to the level of the mid-plane, so that what might first be interpreted as a low head and would result in a low forceps, because of its molding, is actually a mid-head because of the level of the biparietal diameter. The next exception represents extension to the degree of face presentation. Here, the leading bony point is down nearly to the black line, or the plane of the outlet. However, the biparietal diameter corresponds to the red line, which is the plane of the inlet. Therefore, this head should be classed as one which would lead to a high forceps. The third exception to these rules, inasmuch as it deals with asynclitism. This head is in an anterior parietal presentation, and its leading bony point is below the plane of the low mid-plane, as represented by the green line. However, the biparietal diameter, represented by the red line, coincides with the plane of the inlet. Again, we would have, in a forceps done on this case, one labeled as a high forceps. We'll now take up the application of the classical forceps to a head in low or low mid station. It's assumed that the 5 prerequisites are fulfilled. And we know that the head is engaged because it is at low or low mid station. That means that the presenting part is at least within a finger's breadth of the perineum, and that the hollow of the sacrum is entirely filled. And since this is a demonstration of an application of the forceps to an anterior position. Our sagittal suture we find is in the right oblique with the posterior fontanelle opposite 1 o'clock. A good anterior position. We register the degree of desirability of a good anterior position by its closeness to 12 o'clock. The further away from 12 o'clock that the posterior fontanelle lies, the less desirable is the location of the sagittal suture from the standpoint of being in an anterior position. The closer the Y is to 3 o'clock, the less desirable. Between 1:30 and 3 is just about even, and we call that a good LOA. Anything below 1:30 would mean it's a poor LOA, and it complicates the application of the classical forceps. We know that the cervix is fully dilated, and we know the exact position of the head, and we know the station. Now, the final prerequisite of the choice of instrument depends in anterior positions largely upon the shape of the head. Remember that the classical instrument is divided into two groups, those with shanks overlapping and those with separated shanks. The instrument with the overlapping shanks has a short, round cephalic curve, which tends to fit round, unmolded heads. And this particular instrument is the Elliott type. The instrument with the separated shanks have a long, tapering cephalic curve, and this fits molded heads best. Here we have the Lee modification of the Simpson type. So for a fixed rule, we say the Elliott type of forceps for round heads and the Simpson type for molded heads. Here we have a primipara, and in most primipara there is molding. Therefore, our choice of instrument in an anterior position with the head well down in the pelvis. A choice of instrument according to our fifth prerequisite would be a Simpson type because of the molding. In the technique of application, remember that we use the posterior blade technique. That is, the posterior blade is applied first, the one that goes behind the posterior ear in an LOA. That means that the left ear is posterior, and that brings up the four cardinal points of left ear, left blade, held in the left hand, and introduced to the left side of the mother's pelvis. We know that in all left-sided positions of the occiput, the left ear is always posterior. In the LOA, we have a left ear, posterior on the left side. In the LOT, the left ear is posterior, directly posterior, over the sacrum. In the LOP, it's posterior. It's on the other side, but it's still posterior. So that we know that in all left-sided positions of the occiput, the left ear is always posterior. So we follow the technique of the posterior blade first application. Hold the instrument locked in front of the patient in the position in which it'll be after application. And we see our sagittal sutures in the good LOA oblique, and our instrument will be, when applied, in a position similar to this. Because our posterior blade is the one which is behind. Our left hand automatically grasps the handle of the left blade. The right hand, the right blade, so that the right part of the instrument is discarded temporarily, and we proceed with the introduction of the left posterior blade. The instrument is held in the left hand by the pencil grip in a manner in which the fingers can be used to carry out rotation of the blade as it follows the cephalopelvic curve during introduction. The object, of course, is to follow the plane of least resistance. This instrument is held with the toe pointing downward and the convex surface pointed inward, with the shank perpendicular to the horizontal and parallel to the long axis of the patient. Held in other positions, you can see what the difficulties might be. If our shank is not perpendicular to the horizontal, our blade is pointing directly downward and is out of line for the normal cephalopelvic curve. Works either way, whether the handle is directed obliquely to the left or the right of the perpendicular. If the plane of the shank doesn't coincide with the long axis of the patient, the toe would be the foremost portion of the blade would be pointing outward. Couldn't be inserted. If the opposite direction is used, the plane of the shank still not parallel to the long axis of the patient, the toe would be directed inward and would have to be changed in order to follow the curve of the head. The tips of the index and middle finger inserted over the perineum behind the posterior parietal bone to act as a guide for the introduction of the toe of the first blade, the posterior or left blade, going to the posterior or left ear. And the handle is lowered to the patient's right side in the position in which it'll be after reaching its desired location. If the instrument does not remain in place by itself, it is held there by an assistant. Then the anterior blade is applied. The right blade, the handle of which is held in the right hand, is introduced to the right side opposite the baby's right ear. The operator shifts his position so that his back is in the hollow of the patient's left knee in order to be directly opposite his target. And the handle is held perpendicular to the horizontal, and the plane of the shank is parallel to the long axis of the patient. The toe of the blade is guided in a bit more anteriorly than was the posterior blade in order to avoid the posterior frontal eminence. And the thumb is placed on the heel. All force is applied at that region rather than at the handle. And as the blade enters the vagina, the fingers displace the thumb at the heel, and the handle is brought around opposite that of the posterior blade. Then locking is accomplished, and the application is checked. The posterior fontanelle, the Y, should be a finger's breadth anterior to the plane of the shank, and it should be equidistant from the sides of the blades. The sagittal suture, throughout its length, is perpendicular to the middle of the perpendicular plane of the shanks. If the sagittal suture should curve off to one side or the other as it passes below the plane of the shanks, it suggests a faulty application. the brow mastoid application, which should be corrected. Finally, the fenestration is barely felt, if at all, in advance of the head. With those three checks satisfied, one is ready for rotation. And the rotation is carried on the axis of the shanks, slight compression of the handle, and if the occiput is already at 12 o'clock, the rotation isn't necessary. If it's at 1 o'clock, then it's a short arc from 1 to 12 with depression of the handles at the completion of the rotation. Recheck the application. Posterior fontanelle. If we find that the posterior fontanelle is more than the finger's breadth anterior to the plane of the shanks, we know that this is eccentric application. The blades are too far on the face, and the toes go back too far towards the angle of the jaw. And the pivot point of the head, the middle of the biparietal diameter, is anterior to the biparietal diameter of the forceps blade. Hence, traction will cause further extension and interference with delivery. This correction is rather easily made. Unlock the handles, elevate one at a time, top one first, up to the level of the posterior fontanelle. Hold it, then elevate the handle of the posterior blade up to meet it, relock. Then compression of the handles with depression of the head end. There's a slight shift. Some slack is allowed for so that the resultant is the posterior fontanelle, a finger's breadth in front of the plane of the shanks. If the fontanelle is less than the finger's breadth above the shanks, it's an overflexed head. And traction on this would cause the head to hit the perineum and would not go through the mechanism of extension as readily as it would in its normal position. Here again, the correction is easy. Unlock, depress the handles until the posterior fontanelle appears above the plane of the shanks, about a finger's breadth, then compress and elevate slightly. If the sagittal suture appears to diverge to one side or the other after it passes below the plane of the shanks, it means that there is a faulty application. And the correction of that may be shown more readily from the outside. The sagittal suture runs obliquely to the perpendicular of the middle of the plane of the shanks. And the Y is closer to one side of the blades than the other. Here we have the brow mastoid application. That posterior blade is over the posterior brow, and the posterior blade is over the posterior mastoid region. Correction here is a little more difficult, but it's done by unlocking the handles, and the assistant will hold that posterior blade first, that one right below, that's good, and then the anterior blade is shifted forward so that the sagittal suture will be at right angles to the plane of the shanks. Then the assistant will hold that in place, and the posterior blade is moved forward away from the brow so it would be opposite the cheek, as it should be, and then relocked in this position. so that eventually the sacral suture is perpendicular to the plane of the shanks. One may have to repeat this maneuver 2 or 3 times, and even then, on occasions, is unsuccessful in complete success. The final check is for the fontanelle, and for the fenestrations, I should say. If we can put more than a fingertip within the fenestration, it means that there's a short application. And if one continues traction, the instrument may slip off because the toes are not well anchored below the malar eminences. Here there's quite a bit of fenestration in advance of the head. And the toes of the blades are right on the top of the malar eminences. Continued traction might result in slipping, which would cause damage to the mother as well as the child. In the correction, this again is not difficult. Unlock the handles, depress, carry it further up in so that the fenestration disappears beyond the foremost part of the head. The posterior blade is carried in still further and locking. And as a result, no fenestration of not more than the tip of a finger can be inserted in advance of the head. Now for the right-sided position, ROA. And this is a good ROA. The Y posterior fontanelle can be seen about 11 o'clock. Instrument held in front of the patient, the position will be when applied. Posterior blade technique. Posterior blade is put on first. And it's the right blade held in the right hand, inserted to the right side opposite the right posterior ear. The operator stands with his back in the hollow of the patient's left knee. The tips of the index and middle finger guide the toe of the blade posteriorly over the perineum opposite the posterior right parietal bone. The handle is carried downward and around over to the patient's right side in the position as demonstrated prior to application. Then the operator shifts to the opposite side for the introduction of the anterior blade. The left blade, the handle which is held in the left hand, is introduced to the left side opposite the baby's left ear. And the toe is carried in at a little higher level than that of the posterior blade in order to avoid that posterior frontal eminence. And the hand shifts on the handle in depressing it so that the fingers can be put on the heel and lifting the blade around opposite the anterior cheek. The handle comes to rest opposite that of the posterior blade, but as you see, it cannot be locked because the lock is on the handle of the left blade, and it's necessary to cross the handles in order to lock them. This is considered by some as a disadvantage. However, we feel that as a disadvantage, it is far outweighed by the advantage of having the posterior blade in place originally to prevent backward rotation of the occiput during the application of the anterior blade. After locking, the application is checked. And so often is the case in the right side position, there are some corrections to be made. Here we see that the posterior fontanelle is more than a finger's breadth above the plane of the shanks. Fenestrations can barely be felt. The sagittal suture is perpendicular throughout its length to the plane of the shanks. Now, it's best to, before making corrections, to complete rotation to anterior. Compression of the handle, rotation with depression. Now, the sagittal suture is anterior from 12 to 6. But the fontanelle is more than a finger's breadth in front of the plane of the shank, so we make that correction by unlocking the handles, elevating the top one first to the level of the posterior fontanelle, then bringing the posterior handle up to it and relocking. Compression of the handles with depression, and we find that the posterior fontanelle is in its proper place, a finger's breadth in front of the plane of the shanks.